Alright gang, welcome back to our series on EKG rhythms. This will be the last rhythm we look into before we start our exploration of 12-lead EKG. So what we're going to do today is we're going to talk about the AV blocks. And the thing about AV blocks is that AV blocks for some reason cause a mental block when people are trying to interpret these. So hopefully I can show you some ways to understand the AV blocks and to be able to figure it out relatively painlessly. The last thing we need is for the brain to explode while we're figuring these out, but my experience dictates that oftentimes our brains do explode when we're trying to figure this out. So before we go into the AV blocks, I think it's important to remember a little bit of the fundamentals we've been talking about up until this point. And one of the things I've made a point to discuss with you is what I call the primary survey of the EKG rhythm. And as you recall, when we talk about the EKG primary survey, the first thing of course we want to know is about the rate, because just like with driving, speed kills. And similarly, we want to know some other things about our rhythm, like regularity and the presence or absence of P waves and the regularity of P waves. And so let's just review this quickly so that we can apply it to the AV blocks and figure out exactly what it is we're trying to do here. So I'm just going to blow this up so we can look at it and talk about it. Remember the primary survey. So step one, is the rate too fast? Is it too slow? Is it just about right? Obviously on exams and so forth, you have to do a pretty good job of calculating the rate, but in real practice, the answer is just what I've put there. Is it too fast and we need to slow it down? Is it too slow and we need to speed it up? Or is it just about right and we can tolerate this rate? So once I've answered the question about rate, which is of course my priority, it's like the airway of EKG is the rate. The next thing is this rhythm regular or is it irregular? And it helps us to understand if things are regular or irregular because it helps us to come up with sort of a differential diagnosis of what the rhythm is. And by differential diagnosis, we can make a list of things that fall into either category. So for example, if something's regular, of course right off the bat we think of sinus rhythms, but we can also have ventricular rhythms or junctional rhythms that are regular, but we probably don't have ectopy, we probably don't have atrial fibrillation, we probably don't have multifocal atrial tachycardia. I mean, there's some things that we can probably rule out by noticing that the rhythm is regular versus irregular. And if it's irregular, I might think about atrial fib, I might think of premature atrial contractions or premature ventricular contractions. I might think about, again, multifocal atrial tach. I might think of any number of things. So understanding the regularity versus the irregularity can really help us to categorize the rhythm and help put us down one pathway or the other. So then the next thing I want to know is about the P waves, right? And this is very important, and it's important that you understand what these questions mean. But here we go. So are they present? Yes or no? And remember, P waves can be up, they can be down, they can be before the QRS, they can be after the QRS. And so we want to know that. Are they up or are they down? Do they all look the same? If they don't look the same, then they're probably coming from different foci within the atrium, right? Is there a P before every QRS, or in the case of some of our junctional rhythms, is it retrograde P after the QRS? And is there a QRS complex after every P wave? So is there just a P wave hanging out there with no QRS to go with it? If that's the case, then that's going to point you in the direction of an AV block. So similarly, as we're looking at our P waves, we need to understand the PR interval. So I want to know, is the PR interval present? And if it's present, is it the same every time? Or does it move? Does it change? If it changes, well, that's not normal. That's going to put us into AV block territory. If it stays the same, then we're talking about sinus rhythms or maybe atrial rhythms or junctional rhythms. If we have a PRI, we're probably not talking about ventricular rhythms. And the other thing I want to know is if I have a PRI, is it the right size? Is it too big? Is it too small? Is it just about right? So remember, the normal PRI is going to be anything less than one big box, right? So that's 200 milliseconds. So you should be able to eyeball this thing and say, yeah, it's within that one big box, or no, it's too long. And then the last thing we want to know is about the QRS complex. Is the QRS complex wide or is it narrow? And what information does that give us? So let's talk about that for a second, because I think it's something that, similar to the AV blocks, people make this more difficult than it needs to be. So in general, good rule of thumb is if the QRS is narrow, then the rhythm is atrial in nature. So it's sinus, or it's coming from some other place in the atria, but it's originating above the ventricle. So with wide QRS complexes, we actually have a couple of choices. So the wide QRS complex can of course originate in the ventricle, so it can be ventricular, or sometimes we can have a bundle branch block. And a bundle branch block will make the QRS complex lengthen, but we tend with bundle branch blocks to have a P wave before the QRS complex. Whereas with our ventricular rhythms, we tend to not see a P wave. Okay, so a big way to differentiate this is if you see a wide QRS complex with P waves, then I want you to think about a bundle branch block. So here in just a second, I'll kind of remind you what a bundle branch block is, and then we'll talk about the function and purpose of the AV node. Alright, so I told you just a moment ago that I would take a second to talk to you about bundle branch blocks and why they have a longer QRS complex. So let's go back to our cross section of the heart, and as you recall, in a normal conduction system, our electrical stimulation is going to come here to the AV node, and then simultaneously through the bundles of His, it's going to come down here and go both to the right and to the left, and then travel down the Purkinje fibers. And so when everything works according to plan, this takes less than 120 milliseconds, and honestly typically takes less than 100 milliseconds. If, however, I come across here and I put a block right there, then what's going to happen? So this is your right bundle. This would be a right bundle branch block. So now what happens is I've got to come along here. I've got to conduct electricity into the left ventricle, but now it's got to go also from left to right. And when we get into 12 lead in a couple of weeks, we'll see examples of these bundle branch blocks. But what happens then is it slows down conduction, or increases the amount of time it takes to fully depolarize the right and left ventricle. And so the result of that then is what we call a bundle branch block, and that leads to a QRS complex that is greater than 120 milliseconds. If it's between 100 and 120, then we call it incomplete. So it's an incomplete bundle branch block. So while we're here in our cross-sectional analysis, I think it's probably a good idea then to talk about the AV node, since we're going to be talking about AV blocks. And so the purpose, as you recall, of the AV node is to slow and then conduct the electrical conduction into the ventricles, or the electrical stimulation, I should say, into the ventricles. Okay, so in a normal EKG, remember the AV node and its activity is represented by the PRI. Okay, and so here's my brilliant drawing. Please don't judge me, but the PRI starts right here and ends right here, the beginning of the P to the beginning of the ventricular depolarization. So this is the beginning of atrial conduction all the way through the beginning of ventricular conduction. So think about this as conduction point to conduction point. Think about this as you're driving over a lake, over a river, and you have to cross a bridge. and the traffic, the congestion on that bridge. If there's no congestion, the bridge is only going to slow you down a little bit, because the speed limit will probably be a little bit slower on a bridge than it is on an interstate highway, for example. However, if there's a problem with the bridge, maybe there's some congestion there, maybe they're doing construction on the bridge, maybe the bridge is failing and you're having to avoid potholes or whatever, it's going to take you longer to get from point A, which is here, to point B, which is here. So we're driving from the atria into the ventricle, but we have to cross this bridge in the AV node. So when the AV node is functioning correctly, it takes us less than 200 milliseconds to get from the start of our atrial depolarization to the start of our ventricular depolarization. Okay, if you'll think about this in terms of what the individual segments of the cardiac cycle represent, this will be easier to wrap your head around. So again, PRI, beginning of the atrial depolarization to the beginning of the QRS, or the beginning of the ventricular depolarization. Okay, so what we're going to talk about at this point then is how to identify delays going across our AV node. In other words, a sick or failing AV node, and what that looks like electrically. So, like I said before, people want to make AV blocks very difficult for some reason that I don't really understand. Because if you will just think about the individual segments of the cardiac cycle, then it's actually fairly easy to figure out. The other thing that should make this easier to figure out is when it comes to AV blocks, for our purposes, we're only talking about 4 potential candidates. Okay, and these are named sequentially based on least severe to most severe in terms of clinical repercussions. So we have the first degree, the second degree, which is broken into a type 1 and a type 2, and then we have a third degree, which is also called complete heart block. So let's now break these up into their component parts. Okay, so the first degree is very, very simple, and in the setting of the first degree AV block, it's like our bridge analogy from earlier. The bridge is slowing us down a little more than we would like, and it's delaying our ability to get from the start of atrial depolarization to the start of ventricular depolarization. So here's an example in front of us. This is the first degree AV block, and I'm just going to zoom into here, and I'm just going to focus on one of these segments right here. Okay, so of course, let me make my thing just a little bit skinnier. So here you have a P wave, of course, and then this is the QRS, and this is the T, right? By now you know all of that. This is a review, and you should be looking at this going, man, this guy thinks I'm a dummy. No, I'm just reminding you so we're all on the same page. And so remember, the PR interval is right here at the beginning of the P wave to right here at the beginning of the QRS complex. So this is atrial depolarization to ventricular depolarization. And remember, when things are normal, when things are happening correctly, it's less than 200 milliseconds. And you know that if it's less than 200 milliseconds, it's less than 1 big box. Well, let's just get a look at this. I'm going to erase our notations to make it easier to see. And it's clear that this is bigger than 1 big box, right? So essentially, the tip of my QRS complex is almost on here on this big box, and it takes a box and a half to get to the beginning of my P wave. So this thing is probably 300 milliseconds. It's way too big. Okay, so let's think about this in another way, and let's think about it in terms of our primary survey of dysrhythmias. Okay, so the first thing we want to know is the rate okay, and the rate is okay. This thing is just about right. It's not too fast, it's not too slow. So then the next thing I want to know, is this regular or irregular? Well, this is pretty darn regular. In fact, if you just glanced at it, you could be fooled into thinking it's sinus rhythm. So now I want to know about P waves. Are there P waves? And the answer is yes, there are P waves. Here they are. 1, 2, 3. You can see them just march all the way down there. So we have P waves. So the answer is yes. And do they all look the same? Yep, you bet. They all look the same. So they're all coming from the same place in the atria. And then next question, is there one before every QRS? There sure is. So we don't have any QRS complexes that are starting without initiation from the atria. And we have a QRS complex after every P wave, so we don't have any atrial conduction that doesn't make it all the way across the bridge. So now let's look at the PR interval. So the PR interval, we already decided that it's long. Okay, so the PRI is too long, so it's greater than 200 milliseconds. But the other thing I like about this is when I look at the PRI from one cardiac cycle to the next, guess what, guys? They're all the same. And so they are the same. That's good news. And then finally, QRS complex, wide or narrow. This happens to be narrow. So that's further evidence that this originates in the atria. However, like we talked about before, if this were wide, you could think about a bundle branch block in the setting of present P waves. So there you have it. There's the first degree AV block. So the main thing that differentiates the first degree AV block from sinus rhythm is the PR interval. So if you have something that looks sinus, but the PR interval is greater than one big box, or 200 milliseconds, then that's first degree AV block. And so remember, we talked about this before, and it just bears repeating because it's so important. We're talking about the AV node and depolarization through the atria down through the AV node into the ventricles, and the AV node is the bridge. Okay, so anything that affects the bridge is going to affect the PR interval. Anything that affects the bridge could affect the ability of atrial depolarization to be transmitted into the ventricle. Okay, so the bridge, PRI. PRI represents the bridge. Okay, keep that in mind. Remember that with every one of these. So there you have it. First degree AV block is simply long QRS. Okay, now let's move our way on to the second degree AV blocks. Now the second degree AV blocks are a very interesting animal, and I say it's very interesting because there are two types, and we call them Mobitz type 1 and Mobitz type 2. And you will also sometimes hear the Mobitz type 1 referred to as Winky Box. So I think that's kind of fun to say, the Winky Box block. But there it is. So let's see an example of a Winky Box first. And so it's going to be this guy right here. So this is a second degree type 1. Okay, so the first thing we want to do is go back to our primary survey. And so this rate is okay. We'll accept it. So the rate is okay. When we ask the question about regularity, this dude is not regular. Okay, when I say not regular, I don't mean it's constipated. I mean it's not regular. So you can't predict necessarily what's happening here because it's not regular. Now, interesting, it has regularity in groups. So it's regular along here, and here, and here, and then we have sort of this pause. And the reason we have this pause here is because we have a P wave that is not conducted. Right, so the bridge fell on this P wave and didn't allow it to conduct into the ventricle. Didn't allow ventricular depolarization right there. Okay, so let's keep that in mind for a second. So it's irregular, so the rate is okay, and then it's irregular. So now let's talk about our P waves. Do we have P waves? Yes, we do. Do they all look relatively the same? Yes, they do. Is there a P wave before every QRS complex? Well, let's see. I'm going to erase some of our notation here to make it easier to see. So question 1, is there a P wave before every QRS? So P to QRS, yes. There's a QRS with a P, a QRS with a P, a QRS with a P. There's a P wave, but no QRS, but that's not the question we're asking right now. We're simply asking, is there a P wave before every QRS? And the answer is yes. So now the next question we're going to ask, is there a QRS after every P? So here's a P with the QRS, a P with the QRS, P with the QRS, P with the QRS, P with, no QRS. Okay, so we keep coming back to this thing where we're missing a QRS complex right here. We're missing a QRS. It's gone because the bridge temporarily broke and wouldn't let the P wave depolarize into the ventricle. Okay, so then the next thing I want to know, which is going to be very important in AV blocks, is I want to know about my PR interval. And what I want to know is, if I have a PR interval, which I do here, because I've got a PR interval here, and a PR interval here, and a PR interval here, and one there, is are they all the same? And in this case, the answer is no, they are not the same. Not same PRI. Okay, this is going to be very important in distinguishing the Winky Box block or the Mobitz type 1 from its cousins in the AV block family. So in this particular case then, I have a PR interval here, and then this one is longer, and this one is a little bit longer, and this one is a little bit longer, to the point where it gets so far away, blocked by the AV node, that I finally have a dropped beat. So normally I would have a QRS complex right there where my X is, but the temporary bridge malfunction prevented that. And then once the bridge gets fixed, it temporarily starts working again, and then we start over. So you notice this PR interval is the same as this one, and then this pattern will repeat. Okay, so this is a second degree type 1, and the thing that can sometimes be a clue here is you'll see grouped beating. And you'll see irregularity, but it'll happen in a pattern of groups, and that's often your clue to a Winky Box block. Okay, so let's go back over here and make ourselves a note. So type 1, we're going to say grouped beating, and then we're going to say the P wave, or the PRI I should say, gradually lengthens and then drops the QRS. Okay, fails to depolarize into the ventricle. So let's look at this one down here. We're going to go down to this one. And this is going to be an example of a second degree type 2, second degree with a Mobitz type 2. So you'll notice there's something up here that looks pretty similar but is different. We're going to talk about how to differentiate all of this. Okay, so hopefully this will be pretty clear here in just a second. So second degree type 2 is also going to give us a pattern of dropped beats, but it's not going to necessarily give us the same consistent group beating pattern that the Winky Box gives us. Okay, so let's go back to our primary survey so we can kind of do this the same way. So this rate in general is a little slow, but for our purposes that's okay. And then as we look at the rhythm here is clearly irregular. Okay, so kind of all over the place, and if we had a longer rhythm we might be able to say it's predictable or not predictable or whatever, but the reality is it's irregular. So we get to our P wave questions, which honestly are the most important questions when we're talking about the AV block. So first question is, do we have P waves? And the answer is yes. Do we have a P before every QRS? And the answer is yes. So here's a QRS complex and its P wave, a QRS and its P wave, a QRS and its P wave, and a QRS and its P wave. So is there a P before QRS? The answer is yes. Then we're going to ask ourselves, is there a QRS after every P wave? So QRS after the P? And the answer is nada, no. Okay, so look at this. Oh, wrong button. So here I have a PQRS, and I have a PQRS, and then I have a PQRS, and I have a PQRS, and so we know that this is a P wave. What else looks like that? This dude right here, that's a P wave just hanging out on its own. Okay, so in this situation, the AV node is sometimes opening, sometimes it's closing, right? Think of the bridge. So think of this as a drawbridge, sometimes open, sometimes doesn't, and so sometimes I make it across the bridge and sometimes I don't. But when I do make it across the bridge, and this is very important, so if you haven't listened to me yet, pay attention to this. When I do make it across the bridge, the speed limit is the same. Okay, so what am I saying? The PR interval is going to be the same every time I make it across the bridge. Every time there is a PR interval, it will be the same. Repeat after me. The PR interval will be the same in a second degree type 2 block. The PR interval will be the same in a second degree type 2 block. And this turns out to be probably one of the most important questions to ask ourselves when we are looking at these AV blocks. Okay, that's why I told you before, you want to look at the PR interval, and if I have them, are they the same? So go back to this one, first degree AV block, PR intervals, they are all the same. Second degree type 1 Winky Box, PR intervals, they are all different. Okay, that's important. That is a clue that leads you to the diagnosis. PR interval, they are all the same. Okay, so I do have non-conducted P waves that couldn't make it across the bridge. But when I make it across the bridge, the speed limit, the speed with which I depolarize the atria to the beginning of depolarizing the ventricle does not change. Okay, it's very important. And then it just so happens that these QRS complexes are wide, and probably they're wide because there's a bundle branch block. For the purposes of this, we don't care, because for the purposes of this, I want you to focus on the P wave. The car is going across the bridge, the PR interval, the beginning of atrial depolarization to the beginning of ventricular depolarization. Okay? So, second degree type 2 then, the thing I want you to remember about second degree type 2 is what? We've repeated it. It's important. The PR interval is the same. Okay, most important way to differentiate these things is the PR interval is the same. Okay, so now let's move on to the final of these four, and let's talk about the third degree AV block. This is also called a complete heart block, or other people refer to it as AV disassociation. Okay, so remember, we're starting here, we're coming through here, and then we're crossing our bridge into the ventricles. Well, in a third degree heart block, the bridge is closed, it's broken, there is no bridge, you cannot cross it. So what happens then is we will continue to send signals from the atria towards the AV node. We will continue to send cars to the bridge. We will continue to depolarize the atria, but the AV node has fallen into the water, it's dead, and it will not allow anything to depolarize on the other side of it. Well, that's bad news for the ventricles, because the ventricles say, hey, wait a minute, I need some electrical stimulation from up top. So when they don't get that electrical stimulation, you basically get into a ventricular escape rhythm or an idioventricular rhythm. And remember, the intrinsic rate of the ventricle is 20 to 40, and remember that things that originate in the ventricle are wide. So there will be a few exceptions to this rule, but for our purposes of learning, think about AV disassociation as slow rhythms with wide QRS complexes. So they're slow because we are essentially just dealing with a ventricular escape rhythm, right? This is doing its own work. It's automatic. It can produce electricity. So it's doing that. So we're getting a wide QRS complex with the intrinsic ventricular rate. So it would seem like I skipped over some things, but not really. I'm going to go back and show you this rhythm in detail, but I wanted you to understand what was happening using our car and bridge analogy. So in the third degree AV block, we've got cars driving to the bridge. They can't get there. They turn around and go someplace else. So the cars on the other side of the bridge see what's happening, and they turn and drive away slowly. And in that case, that's our ventricles beating at 30 times a minute. So as we do our primary survey here, what do we notice? We notice, first of all, that this is slow. Okay, it's a slow dude. It's probably about 30. If this was a 6-second strip, this would be a rate of 30. Okay, so step 1, it's slow. Step 2, it is fairly regular, isn't it? Okay, and it's regular because we have a ventricular escape rhythm right here. Okay, and we'll talk more about how I know that in a second. So it's regular, it's slow, it's very slow. And then let's talk about our P waves. Do we have P waves? And the answer is yes. Is there a P wave before every QRS? And the answer is, yeah, kind of, but not really. So we can expect to have QRS complexes without P waves in front of them. And in fact, here's one sitting back in the T wave. And then, most importantly, the question is there a QRS after every P? And the answer is heck no. So here's a P wave with no QRS. Here's a P wave with no QRS. Here's a P wave with no QRS. Here's a P wave and another P wave with no QRS. Okay, so is there a QRS after every P? And the answer is not just no, but no, no, no. Okay, so we've got this thing. It's slow, it's wide, and it's a rather bizarre looking rhythm. So what I want you to notice then is the activity here of the P wave and the QRS, or the association of these two in particular. So remember, if we're using our car analogy, and I've got my block here, the ventricle is completely unaware of what's happening above it. Okay, so there's a party of cars going on up there, and the ventricle thinks everything is dark and quiet, and it's singing Simon and Garfunkel songs because it doesn't know what's about to happen. So check this out. If I look at my P waves, just my P waves, I'm going to kind of zoom in here. So if I look at my P waves, I can take this P wave and I can march them out independently. So the distance from here to here should be about the same from here to here to here to here to here to here, here to here and here to here. So in this case, the P wave is beating at essentially the atrial intrinsic rate. Okay, so in this case, 1, 2, 3, 4, 5, 6, 7, the atrial rate is somewhere around 80 here, but the ventricular rate is 30. Okay, so one clue is the rates aren't compatible with one another. You can't even make the argument there's 2 to 1 or anything like that. So this fraction doesn't reduce into anything useful. So you know, basically there's 2 2/3 P wave for every QRS complex. And so we can take those P waves and we can see how they march out independently. And then similarly we can look at the QRS and they do the same thing. Okay, so a clue to a third degree AV block when you're looking at this is that the P waves march out and they just keep going on their own with absolutely no correlation to the QRS complex. And so that's why this is called AV disassociation or complete heart block, because the P waves, the atrial depolarization, is not making it to the ventricle. And because this is most often a ventricular escape rhythm here, we're going to see this wide QRS complex. And because it's ventricular escape, it's going to tend to be slow. Okay, so obviously there's exceptions to every rule, but in general what we're going to see then is it's going to be slow, it's going to be wide, and then we're going to have AV disassociation. And probably when we look at the atria, they're going to have a normal intrinsic atrial rate. Alright, so what I want to do now to help you hopefully kind of categorize some of this stuff is I want to take a minute and see how our rules can help us sort of understand what's going on with the bridge of the AV node. Okay, and let me see if I can make a little graph here. Okay, so we're going to have our first degree AV block, our second degree type 1, our second degree type 2, and our third degree. So first thing I want to know is, do we have P waves? And the answer for all of these is yes. Can't get away from that. Okay, are they wide or normal? Okay, they're most commonly gonna be wide when they are appropriately present. They don't have to be, but they often will be. Okay, and then with that, are they consistent? Okay, so in a first degree heart block, they are long, but they are consistent. Second degree type 1, they are not consistent. Second degree type 2, remember I told you over and over and over again, when you make it through the bridge, the speed limit stays the same, so they're consistent. And then in the third degree, of course, they are not consistent because they are completely disassociated. Okay, and then let's look at the QRS complex. Okay, we know that the QRS complex can be narrow or wide in the first degree. If it's wide, it's going to have a bundle branch. Same thing for the second degree type 1 and 2, but in the third degree, more often than not, it's going to be wide. Okay, so let me ask you a couple other questions here while I'm thinking about it. I got myself a little bit out of order, but that's okay. So, is there a P before every QRS? So, first degree, yes. Okay, and we know that that PR interval then is going to be greater than 200 milliseconds. In the second degree type 1, is there a P before every QRS? And the answer is yes. Okay, we know, however, that they are going to lengthen each time until they reset and start over. In the second degree type 2, is there a P wave before every QRS? The answer is yes. And we know that whatever the PRI interval is, it's going to be the same. Okay, that's so important. And then finally, in a third degree AV block, is there a P before every QRS? The answer is a big fat no. And then the last thing is there a QRS after every P? And so let's figure that out very briefly. And it should be by this point obvious. So in the first degree AV block, yes, there is a QRS after every P. But for these other ones, the answer is no, right? So in Winky Box, remember, PR gets longer and longer and longer until finally it's so long it can't cross the bridge. And so we'll have a P wave that is not conducted through the AV node. In the second degree type 2 block, we have intermittent failure of the bridge, and so we will have some non-conducted P waves. And then finally, in the third degree block, where the bridge is completely shut down, similarly, we will have QRSs without Ps and Ps without QRSs. Okay, so let's do a brief review of the important parts as we conclude here. Okay, and I'm not, in this brief review, I'm not telling you everything you need to know, but I'm giving you some hints as to what's going to help you. Okay, so when I think about this, if I had to say, one word that is really going to help me differentiate, so first degree AV block, it's got the big PRI, 200 milliseconds. Second degree, type 1, grouped beating and progressive widening of the PRI, and then a drop. Second degree, type 2. This one is not grouped. This one has dropped P's, meaning you have a P, actually let's call them a dropped QRS. You have a P wave with no QRS, but when I do have PRIs present, they are what? They are the same. And then finally, third degree is AV dissociation. So the P's march out independently, the QRS marches out independently, and then because of that, you will often have ventricular rate of 30-ish, and you will most often have a wide QRS. Alright gang, I hope I didn't confuse you tonight. I hope, in fact, I helped you some by giving you some ways to keep these things separate in your head. But remember, it all comes down to this right here, the AV node, understanding what the AV node does. And remember, it's a bridge. It's a bridge from here to here. And so when the bridge isn't working appropriately, we can't get our conduction through there into the ventricles. As always, if you have any questions, give me a shout.